morning, I'm Yong. I'm working in the Department of Odontology in Seoul National University. First of all, thank you for giving me the chance to present here as a speaker. I appreciate too the thank you for the big conference in DEC 2025. And today's my lecture is Quick Aesthetics with Collagen Graft. Okay, right? Let's go. Yes. Today's my lecture is about the Quick Aesthetics with Collagen Graft 2 and HA, movement of fillers, and also additional PDRN. Okay, so today I would like to introduce about my aesthetic treatment, especially as I am a dentist. There's many patients come to my clinics for the treatment of black triangles and also the gingival recession, and additionally about the wrinkle care, the capillary wrinkle, including the major holes and vertical lines, and also mental crease. So nowadays I try to do the aesthetic treatment in my clinic. So I would like to share my clinical data and also research data about the soft tissue management with the Collagen Graft 2 and the modern fillers and PDRN, which are produced by the genus in dentistry. Okay, the first one is the soft tissue regeneration, especially the parental biotype modifications, PBM. It means the increase of thickness and also the volume of the soft tissues. So patients with the thin gingiva tends to have the thin bone. In the case of the thin bone, it can make easily the bony transpirations and also descent. In the case of the thick gingiva, it doesn't matter, even though they have the bony transpiration or descent. However, in the case of thick gingiva, it can make the gingival recessions. That means the decrease of the aesthetic point. So the dental implants as well as the laser tooth can make gingival recessions. It is especially in the immediate implantations. The buccal bone was there when we do place the implant fixture inside, but as time goes by, the buccal bone disappeared. And then, in the case of thick gingiva, it doesn't matter, right? But in the case of thin gingiva, it can make the gray color gingiva and also the horrible, the fixture exposure like this. So it can reduce the aesthetic point. So as a periodontist, I always try to make the thin gingiva to thick gingiva because it is very useful and more good for the aesthetic points. So this means the periodontal bioclimatizations from thin to thick. Generally, there is two representative methods for the PDM that is usually can say that will be covered. The one is freezing graft FGG, and the second is the connective tissue graft CTG. In the case of FGG, we can have advantages because we can get a big increase of the gingival thickness because the axillary layer, and you can get the axillary layer and also connective tissue layers when we get the FGG from the palate. But have you ever checked the color and texture at the palate and the first side? It has a little bit difference between them, so it can make inharmonious the color and texture when we do the FGG at the anterior part. Therefore, in the case of the anterior part, the connective tissue graft CTG has been considered as golden standard for the root coverage. But it is very harmonious in the color and texture, but it needs more skill because you have to remove exterior layers and you have to use just inner part. And also you have to put the tissue graft inside and you have to cover the original occurring plaque with the coronary advanced plaque. So it needs more skill. But when we do the FGG or CTG, the patients always say about the discomfort and also pain from the palate, not the upper side, right? So it can make us a very stressful conditions. It can make the stress to the patients and also to the dentist. So we need the method and any other ways to make the palate free that can make us the stress-free conditions to the patients and also the dentist. So nowadays, I do not touch the palate anymore because I don't need anymore the autograft like FGG and CTG because I usually use the collagen matrix instead of FGG and CTG. So nowadays, I usually do like this in the PPM. I make a vertical incision like this and around the gingival incisions and make a full thickness tunneling and put the collagen matrix inside and then suture. That's all. So the advantage means there is no donor side. I don't touch the palate anymore because I need the autograft. But many dentists say about the disadvantage that is a relapse. I agree with that. In the past, it was. But nowadays, with the development of the technology, I think that there's no more relapse. It is similar with the CTG. I will show you about the preclinical and also clinical data later. So today I would like to introduce about the Collagen Graft 2. This is made by Forsyth Cancer-derived type 1 collagen and it has a bilayer structure. The upper layer is dense structures and the lower layer is the coarse structures. And before hydration, it looks like a little bit rigid. But after the hydration, you can see the very smooth structures and also textures. So we can use it very easily when we do the PDR or the PDM. So, and there's many various sizes, so you can use easily according to the defect size. So nowadays, I use this technical wall this is made as simplified economy techniques to act around the gingival incisions and make the vertical incisions and make the full thickness tunnel because it is already very thin, so we don't need to make a partial thickness. We can make just full thickness, the tunneling, and then put the collagen matrix inside and then suturing. That's all. It is very simple, right? And this is a movie about the vertical incisions around the gingival incisions and make the full thickness, the tunneling, both sides of vertical incisions. Like this, and then you can close the gingival incision with the suturing. Right? You can close the gingival incision like this. It is very easy, right? So after making sure the closing the gingival incision with the suturing, we can apply the collagen matrix inside like this. So you have to make the full thickness, the both sides of the incision, because it can make it stable the positioning when we apply the collagen matrix like this. So after applying the collagen matrix inside and then make a suturing, and then that is the completion of the simplified economy technique. So it is very easy, right? So I usually use this technique for the PDM. So I would like to about the mechanisms of the tissue regeneration with the collagen matrix. So the key point is the porous structures of the collagen. These porous structures make easy cell ingress inside and also the easy vascularization. That means finally the well tissue integration and also regeneration. So many people ask me about that. Then what does the collagen turn into? The answer is connective tissue. So we don't need to touch the collagen to get the connective tissue graft. Why? Because the inserted collagen graft tube can change to the connective tissue. So don't touch the collagen anymore for the PDN. So I'd like to share my research data. This is the preclinical studies in the vivo models. Because I told you the connective tissue graft, CTG, has been considered as a gold standard for the PDM because many scientists thought about that the disadvantage is the relapse of the collagen matrix. So I wonder, is it right? So I did to make the scientific evidence about that. So we compare the collagen graft tube and the autograft from the dog product, the CPG, and did the PDM at the same position. And did the histometric analysis and in situ chemistry analysis, and also we did 3D polymetric analysis. This result shows that there is no significant differences in the thickness and volume between the CTG and the collagen graft tube. So this result shows that there is no significant difference between them, and it means collagen graft tube has a similar clinical impact like as the CTG. When I show you this data, many scientists ask me that is just preclinical data. So I prepared the clinical study data. Because we used the collagen graft for a very long time, so we had long-term clinical outcomes. So in our department, we do the retrospective study and also publicate the papers about that periodically, about 4 or 5 years term. So this clinical outcome shows that the Collagen Graft 2 has shown a similar clinical effect like as connective tissue graft in the PDM. So I recommend to use the Collagen Graft 2 when you want to do very easy and simple treatment for your gingival recession patients. And next is the alveolar root preservation. We usually do the ARP. I usually do ARP because ARP can prevent the reductions. It is very well known that after the tooth extraction, the alveolar bone is reserved. So if you want to maintain or if you want to get the enough bone for the dental implant placement, it is needed to do the ARP when we cannot do the place implant immediately. Right? So I usually do ARP when I cannot do place the implant immediately after the tooth extractions. So this is my clinical procedures about the ARP. In the past, I usually use the collagen membrane for the covering the extraction settings. So after the tooth extraction, and I did the removal of granulation tissue and clean the extraction sockets, and then put the collagenated bone right as general collagen, and then covered with the collagen membrane. I used the BioBite in the past. And then, because I always do the open healing in the case of ARP, I used to do the hidden access suture like this. And then I apply the copet for the patient's comfort. And then you can check that after the 1 week, when I do the stitch out, you can see the soft tissue is well healed, right? And after the 4 weeks, it shows that the well healed soft tissue, right? But when the Collagen Graft 2 was introduced, I used the Collagen Graft 2 instead of the BioBite. So the same procedure after the tooth extraction and the removal of granulation tissue and cleaning the extraction sockets and put collagenated bone graft inside. But the difference was I used the Collagen Graft 2 to cover the extraction sockets. And also I did the open healing with the hidden access suture. But I could get the big difference after the 4 weeks of the surgery. Can you see that? When I used the BioBite, the gingiva was well healed, but the thickness is very thin, right? But in the case of Collagen Graft 2, it shows very stable and also thicker gingival tissue regenerations. So after that, I changed my materials from the BioBite to Collagen Graft 2 for the stable and also thick gingival regenerations. So because I'm working in the university because I'm a professor, I always try to make the scientific evidence. So in this case, I also did bigger experimental model, the experiments, and we made the distance detect, and then we did an ARP, and we used the same bone graft materials, but the difference was to use the membrane, and the other was the matrix. So that was the comparison between the BioBite and Collagen Graft 2 in the ARP. And after 20 weeks, we did the sacrifice and did analysis using the 3D disperse scan and microcity analysis and crystalline analysis. This microcity data shows that when we use the Collagen Graft 2, we can make more good and stable bone regeneration. And also, this histologic data shows that we can see the very thicker and also the stable gingival regeneration when we use the Collagen Graft 2, and also the underneath bone regeneration shows that more good, more great bone quality and also the quality. So I nowadays usually use the Collagen metrics, especially Collagen Graft 2, when I do the open healing. So these patients came to my clinic. The chief complaint was he said in the local clinic, the dentist said that implant placement is impossible. But she wanted the implant placement. She already got the implant failure in that positions, and you can see that the metal, the cartilage tissues, and also the particular defect, right? But we have to place implants, and also we have to make the bone. So I did write this. This is the clinical outcomes. I successfully placed implant, and also I successfully made the bone vertically. So I would like to share the procedures. Because there is the very thin, the cartilage tissue, so I try to make a widen the cartilage tissue. So I plan to do the open healing. So I place the implant on both sides and then put the collagen graft inside and then use the Collagen Graft 2 because I plan to do open healing. Because I told you the Collagen Graft 2 is very strong in the case of the open healing because it can make the proper and good soft tissue regeneration, and also it can make good bone regeneration that underneath the stable, the gingiva. So I did breast implant and simultaneously did the vertical procedure, and I did open healing with the Collagen Graft 2. So after 1 week, you can see the gingiva is low, regenerative, and also after 1 month, you can see that I could get the cartilage gingiva and also low fill the gingiva around the implant. And after 1 year, you can see it is very well maintained. So before and after, you can compare the clinical outcomes. The narrow the cartilage gingiva was widened with the open healing using the Collagen Graft 2, and also we could get the particular bone regeneration using the collagen bone and also Collagen Graft 2. I just did the simultaneously the place implant and also the particular procedure using the Collagen Graft 2 because it was very stable when we do open healing. So don't worry about that when you plan to do the particular procedure or open healing using the Collagen Graft 2. So this is the follow-up data from the 2021 until 2025. It is well maintained until now. And I would like to share my techniques. I always say that this is very easy and simple applications of Collagen Graft 2. In the case of the immediate implantation, we always see the buccal bone when we do place implants. But as time goes by, the buccal bone can disappear, right? It is much more in the case of the very thin buccal bone. So in that case, you can make the buccal descent like that, right? The reason why is the thin buccal bone and also the thin gingiva. And also, in the case of immediate implantations, you can make the fixture positioning, right? You have to place the fixture more properly and more liberally, but in the case of immediate implantation, it is very difficult. So in that case, you can make the buccal descent like that. In the case of the thin gingiva, we can make the gingival incisions so we can decrease the acidic point. So because there's no buccal bone, so we have to do hard tissue regeneration or just soft tissue regeneration. So there's two options. Option one is GBR and option two is soft tissue regeneration. Let's look at the option one, GBR. You have to think about this point because it's already contaminated surface and also it has a lower osteogenic potential because there is no work, right? And also the implant fixture is not good position. So if you put the bone graft materials and also you cover with membrane, but there's no bone anymore, right? Because that is the limitation of the structures and also the conditions. So in that case, I do not put bone materials. I just apply the plug-in methods because the patient just wanna increase the acidic point. They don't know about the whether there is a bone is there or soft is there. They just wanna the increase of the acidic point. So this patient came to our department. She said, my gum color is gradually changed to gray. Is it normal? Normal? I don't think so, right? We can imagine that underneath the gingiva, there is the exposure of the implant fixture, right? I think that is the error of the positioning of the fixture when the dentist did the immediate implant placement. So when I open the tab, I clearly saw the implant fixture exposure and there's no buccal bone. And also the crystal part is towards the buccal side. So there's very low potential to make the bone additional. So I tend to do just apply the polygraph too. I think just to do PDN because the patient just needs to increase the acidic point. So I try to do the soft tissue augmentation using the Collagen Graft. And then after the application of Collagen Graft 2, and then the fixture, and then switch out, and let's compare the whole. And after, you can see after the treatment, the clear, the carotid tissue, and also the thicker gingiva, and the patients agreed the clinical outcomes, so she came back to the local clinic for the final process. So we can do PDN without the bone graft material in the case of buccal descent. Why? With what? With the Collagen matrix, especially Collagen Graft 2. And also, I usually use the Collagen Graft 2 when I do the buccal contour reconstructions. When we do the tooth extractions in the case of the periodontally compromised case, we can make the buccal detect like this. So we can make the concave the buccal contour. So after the face implant, you can see the buccal descent like that. So in that case, I just cover the buccal descent with the Collagen Graft 2 applied to the healing attachment like that. Because I just need the focal contour here and reconstructions. So for the application, you can see the concave, the focal contour, right? But after the application of Collagen Graft 2, you can see the convex contour. So we could get the focal contour reconstructions without bone graft materials, just with the collagen method. So it is very easy and simple. Why? So you can see the color data. It is well maintained, the convex, the focal contour. So we can do the very easy and simple treatment. So it is very useful to use the Collagen Graft 2 when the focal disease is not a severe condition. So we can see the before and after, the concave focal and the convex, the reconstructions after. And because I just applied the Collagen Graft inside and I did not have any chance to check it is just connective tissue or the bone regeneration inside, so I decided to do check. So after the place the implant, you can see the focal distance, right? So I could do the connect, the healing attachment, but I plan to do the second stage procedure because I want to check when I just apply the collagen graft inside without the graft material when I do the second operations. So I just apply the collagen graft to the side and I do not apply the graft material inside. So after the 4 months when I do the second operations, I was very surprised because there's, can you see that? The bone regeneration was whole there. I just put the collagen matrix, no bone graft materials, but the bone was regenerated with the focal bone and also it was covered, the cover screws. So I finish it after the removal of the bone and connect the ultimate healing and the prosthesis was delivered. So I compared for whole after. So I just put the collagen matrix inside, right? But the line of the bone regeneration was protected, coincide with the line of the collagen matrix. So we can think that about the key and basic mechanism of the guided tissue regeneration, right? The key material is not the bone graft, right? The key material is the membrane or matrix to block the excellular cell migration into the bone defect, right? So when we apply the collagen matrix like this, I mean that means the concave the structures which has high potential for regeneration, it can make the good bone regeneration and also more thicker deeper regeneration. Just using the collagen matrix. So there's many cases about the using the collagen graft 2 in the focal distance impact. So in our department, publicated about that. So if you wanna know in detail, you can search these papers. And let's move to the part 2, that is the pink acid treatment with Immunoreja HA filler. So the period ring makes us the old paste, right? It contains the nasolabial fold and the margin line and metacrist. So I always try to do repeating of the pace using the lever volume of tools. So today I would like to introduce the molecular pillars for the lifting of the pace and also the treatment of the black triangles. So this is a high elastic monorail lubricate HA filler. There are two types. The one is smile and the other is volume. So it is very easy. The smile is a soft filler and the volume is a hard filler. So there's two types. And let's look at the skin component from the base. So the skin is composed of epidermis and dermis. And underneath the skin, it is the subcutaneous tissue that is usually plastic tissues. And also, this skin contains extracellular matrix that is usually the elastin and hyaluronic acid and collagen. So the hyaluronic acid HA acts as the hydration because HA attracts the water to moisturize and also make an elastic skin. And also, HA stimulates the fibroblast to increase the collagen production. So it is very helpful for the skincare, right? So in the cosmetics, the HA is widely used for the skincare items. So let's look at the wrinkle formation. In the young age, there is no problem because there is a plentiful and the HA and also elastin and collagen. But with aging, the content decrease and skin elasticity also decrease. So the empty space causes the deep hoarding, which means the deep wrinkles, right? So it makes us the old face. So let's look at the underneath the skin. I told you there's the plastic tissue layers, right? In the middle of the plastic tissue layers, we have to focus on the smooth layers. The smooth is the superficial, muscular, aponeuroteic systems, which cover the entire piece. So the lower part, that is the deep plastic layer, the ligamentous tissues, it looks like a stem of the tree, right? But the superficial layers, the ligamentous tissues looks like a branch, right? Like a tree. In the young age, this tree is very upright, very straightforward. But with the aging, the tree is cracked, making the body. It is a wrinkle, right? So my practice of the anti-aging is the fill the concealer in the lower part and putting fill with the subcutaneous, the superficial part. So it can make the upright and restore the tree white, the smooth layer again. So that means the tightening of the smooth layer. So I apply the fillers, the top fillers bottom and the subcutaneous in the upper part. The top filler, it means the volume. In the case of the modern fillers, is the first smart and also the tightening the bottom. And the subcutaneous, that is smile. It can fill the loose part and smooth the surface. So let's look at the strategies of tightening smooth layer in the medical part. They usually use these items, right? Like a HIFU or the laser, ICL or fractal. That means make a shaft to the smart layer to make straightforward and aligned structures. And also they use the mechanical tools like as thread ripping, right? But it needs the physical tools and techniques. So I would like to introduce the intraoral injections of the filler because you're dentist, right? So we do the anesthetic injection every single day. So it is very easy to do intraoral injections filler inside. So in the case of the visual holding volume up, we apply the filler inside that is usually the location of the canine, the upper side. So you just touch the bone and then uh, distract a little bit and then spread the filler above the bone, focusing to the peptide tissues, the underneath the smooth layers. And then we do is the order approaches like this. That is the same method of the medical part. That is just focus to the superficial skin. Right? So I usually use the volume fillers in the intraoral injections, and also I use the smiley fillers for the superficial skin injections. These patients told me the complaint. His complaint is a deep visual report, and he wanted to make a young face with the volume up naturally. So I did like this. So let's look at the procedures. Because it can make a pain to the patients review the intraoral injections, the anesthesia. It is very easy, right? We always do the anesthesia injections. So after that, we can apply the filler inside. For the making the volume up in the bottom, we inject the filler inside like this, just underneath the visual hole. You can touch and you can feel the needle inside. And then you can feel the bottom up when you feel the filler inside. So you can make very tightly and bottom up the visual cord using the intraoral injections. So after the completion of the intraoral injections, you can do the molding, right? Because the filler is very flexible, so you can make a shape according to my hands, right? So you can focus and concentrate the filler just finish underneath the visual cord to make more bottom up, right? So we do the molding like this. And then next, we finalize using the extraoral injection of the filler. That is, you just make the soft appearance using the soft filler at the superficial tissue layers. This is the same method of the medical curve, the filler injections. It is very easy. So the main volume up is using the volume filler via the intraoral injections, and the minor part is the extraoral injections. So you can do the lateral volume up using the intraoral injections, the perioral vehicle. So this is a completed appearance, and the patient was very satisfied with the clinical outcomes. And let's look at the black triangle. How can you the treatment for these patients? The black triangle decreases the exit point, right? And also it can make the food infection inside. And also, it can make the cognitive issues, the escape of air, and also the saliva. So there's the represented two parts of the treatment of red triangle. The one is the white, that means the prosthetic or the restoration part, right? And the other is the pink, that means the periodontal point of view, including the mucogingival surgery. I tried to do the mucogingival surgery in the case of red triangle, but it always makes a relapse. So, and the mucogingival surgery is very difficult to make the proximal gingiva, right? So, many dentists select the white treatment option because it is very easy and very dramatic, right? And also it is non-invasive treatment option. So many dentists want restorative treatment like as a resin or laminate, right? But in that case, it can make the gingival inflammation because they block the interproximal part with the restorative materials. So it can make the gingival recession and gingival inflammation, and also it can make more the bone resorption and make more the big like triangle. So the bad circle, right? So we can think about the easy and simple way to the treatment of the black triangle using the number HA filler. Because the face is also skin, right? And also gingiva is also skin. That is just introverted, right? So we can just think very easily. We can make a volume of the gingiva using the number fillers. Why not? So I try to do like this. So you can just apply the fillers and proximal part, and you can get the filling in the proximal part like this. So you don't need any more the white treatment, right? So at first I thought that, oh, this is my first clinical outcome, and also I'm the initiator. But it was not. Many dentists already using this method to make a gingival volume up without fillers. And they told us that we have to do the step-by-step procedure, not just one shot, right? Because we have to think about the difference, the facial skin and the gingival tissue. As I told you, in the face, we have very thick tissue, right? And also, when we apply the filler in the face, that is targeted to the plastic tissues. But we don't have any plastic tissues in the gingival tissue. So we have to think about the difference. The gingival tissue have enough the gingival fibers. It means it doesn't have enough space to make the volume up. So we have to try step by step. It means once injection and twice injection, right? Until the interproximal part is filled with the soft tissues. And we have to think about the classification. It means indication, right? The Dr. Panel said that we can classify the loss of popular height class 1, 2, 3. In the case of class 1, this means the proximal gingiva is located between interdental contact point and the proximal C-base. It is class 1. We can make a full and complete filling when in the case of class 1. But in the case of the class 2, we cannot. We just can do the partial filling. So we plan to make the class 2 to class 1 and then finish with resin or laminate, right? That is half and half. half white and half pink. But in the case of class 3, it means the below the facial CJ don't touch because that is the contraindication, not the indication. So we just do in the class 1 and class 2. And also, in the monoid filler, you can meet the needle with the bevel, right? So because we have to make the filling toward the tooth contact point, this bevel has to toward the tooth contact point. So the bevel has to make a toward directions the tooth contact point. So this is a method of injection of filler of black triangle. So make the imagination of the facial CJ. So if the proximal part is above the facial CJ, you can do the filling up with the filler. So just touch with the thumb or fingers that white line and then inject the filler like this. In the upper part, the bevel has to toward the lower part. And in the lower part, the bevel has to toward the upper because you have to feel the proximal part. So you can do the black triangle treatment with the HA fillers like this. So we can make the complete gingival, the regeneration and polishing off using the HA filler like this in the class 1, but in the class 2, from class 2 to class 1 is good, but the other is the white treatment. But the class 3 is impossible, so don't touch that. You have to find the other treatment also, right? Because it means very severe bone reductions and also severe visualization. So if you want the using the filler, making the PDN using Collagen Graft 2 is the first. And then you do the filler injections in the proximal part. So my recommendation is just do in the class 1 or class 2. In the class 2, the white 50% and pink treatment 50%, and class 3 don't touch. Okay, so you can make proper contact point, no more contact line, because you can induce the gingival inflammation and bone reductions and pelvic circles again. So I recommend to do the black triangle treatment using the HA fillers. But we have to think about this side effect, right? The complication is the necrosis because it means that the filler can block the blood supply. So I told you we have to do step-by-step injection of filler to the gingival tissue because it doesn't have the pectic tissues. It is almost a hybrid. So it doesn't have enough space. So at the first shot, you have to make more flexible space, and you have to wait. It is about 1 or 2 weeks. So after 2 weeks, you inject again, right? But in this case, the dentist just puts the filler with the pressure. So these fillers, the spread to the polypus and block the blood supply, and it makes clearly the halt necrosis, right? So you have question about to use the filler in the gingival tissues, but we have solutions, right? Because this is an HA, so we can insert with the hyaluronic base. So if the HA filler blocks the blood vessel, don't worry, because you can insert with the hyaluronic base, and it takes 22 hours to insert HA, and also it can be getting out of the body by lymphatic circulation in these 2 weeks. So if you wanna resolve again, you have to wait 2 weeks, right? After 2 weeks, apply the healing base again. And also you have to say about the side effect, right? Swelling, redness. It would be possible to the patient, right? So don't worry about the blood vessel because we have the solutions. And then next is PDRN. We usually use PDRN in your dental clinic. It is widely used nowadays in Korea because it acts as a tissue healing booster. And in the journals, then you make the cosmetic like this, the essence and the mask, face mask. In the past, the first version was PDRN was 5,000 yen, but the second one is the concentration was increased, the 20,000 yen. So I also use this essence on and the face mask it works well, so it can make us very beauty taste. And I'd like to introduce about PDRN, that is abbreviation for the polydeoxyribonucleotide. And it is originated from the salmon, right? So it is known as the salmon injection in the medical part for the aesthetics. And in the Korea, it was commercialized using in the curing wounds and also the tissue regeneration. So we can use the PDRN for the tissue regeneration and also the utilities. Let's look at the mechanism and also clinical effect of PDRN. The PDRN binds to the A2 receptors and stimulates the abstract, eject, iject production. And also it can stimulate the proliferate and also the differentiate the fibroblasts, osteoblasts, and chondrocytes. Finally, it acts the wound healing and also anti-inflammation and also finally the tissue regeneration is. So the PDRN is widely used in the periodontal tissue regeneration, right? In the case of periodontal treatment, it is usually the inflammatory conditions, and also we always need tissue regeneration. So PDRN can be used in the dental clinics. And because I always try to make the evidence for my dental application, so I did also the in vitro experiments. When I compare the PDRN with the HA, the cell proliferation was increased when I used the PDRN. Also, the cell migration was faster when I used the PDRN than HA. And also, PDRN promoted the collagen depositions like this compared to HA. And the PDRN also has an anti-inflammatory effect. It reduces the interleukin 6. So we could conclude that the PDRN has the increased proliferation and also increase the migration and also the reduce the inflammation. So I had applied the PDRN after the tooth extraction for the soft tissue healing. When I compare the control and the simple applications of collagen graft and the stocking of PDRN in the collagen graft, you can see that when we use the collagen graft, it can increase the healing potential. And also when we use beyond the stocking, the PDRN, the collagen graft, we can see the more increase the healing potential. So I could conclude that the PDRN can increase the deeper healing potentials after these expressions. So I would like to introduce my dental application of PRN. So I usually use two methods. When I do directly to the Pinjiga, I use the insurance rings because the needle is very tiny, so it is not painful. It is very easy and very useful. And also, I always soaking the PRN in the Collagen Graft like this. So I would like to share my clinical cases. These patients had a severe bone reductions, right? You can see that he had a severe visualization also. So, because the severe bone reduction and the soft tissue reductions, we can think the delayed implantation, right? Because there is no bones, But I usually do the immediate implantation because to reduce the time at fault. And also, I always try to use the intracerebral granulation tissues because we can use that as a covering materials. So I did the liver incisions and then make more the buccal fat using the IGT. And you can see that granulation tissue like this. Because it is granulation tissue, it has the inflammatory potentials, right? So we wonder about the use of IGT, but don't worry, because we have PRN, right? It has anti-inflammation action. So I place big one inside and apply also general collagen inside and covered with collagen graft too. I use the soft, the PRN soaking, the collagen graft too, and then covered with IGT. But you could see the open healing a little bit, right? But don't worry because I use collagen graft too. It is very strong, right, in the open healing. And I apply the compact to make the comfort the patient from again to the infection and also pain. And after 1 week, you can see the soft tissue is low, healed, right? And also after 1 month, you can see that the soft tissue is low, healed, the cover, the defect. Right? So after 3 months, I did the second operation and finalized. So after the process delivered, you can see that the clinical outcome is good, right? So in the case of severe conditions like this, we can use the simultaneous, the immediate implantation and also the post regeneration using the collagenated bone and also the collagen graft. And also we can make the stable tissue regenerations with the PRN because it can enhance the proliferations and also cell migrations and also the anti-inflammations. So we can use the combined materials and we can get the good, the successful, the clinical outcome like this just within 4 months. So I'd like to give you guys a take message. Collagen Graft 2 helps the PDM easily and simply. And also, the Mona Lisa is circular, can encourage the aesthetics via laser volume up, and also including the triangle treatment. And the PRN can increase the regenerative potentials with anti-inflammation. Because I usually use collagen graft and monocular and PRN, so I publish about the review papers, so you can find these review papers for your the information in detail. So thank you for your attention, and this is my final presentation. Thank you.